Well, of course, asthma is defined based on the demonstration of variable airflow obstruction. And I think what we've learned in recent years is that there are different types of asthma, and it's simply not good enough to identify asthma. You need to identify what type of asthma the patient's got. So type 2 high asthma, so this is asthma with evidence of type 2 airway inflammation, is a particularly important asthma to identify because we know this group of patients are at high risk of having asthma attacks, and we know they respond particularly well to corticosteroids and to biologic agents. So I don't think in the 2020s it's sufficient to diagnose asthma. I think you've got to go beyond that. You've got to characterize the asthma. And there are two processes that I would be particularly interested in measuring. One would be airflow limitation, because we do have good treatments that can improve lung function in asthma, and patients are likely to benefit from those treatments, so bronchodilators. And secondly, type 2 airway inflammation, because we've got good treatments that can modify that. What we now know is that there is not a very close relationship between disordered airway function on one hand and type 2 airway inflammation on the other. They are to some extent, independent treatable traits that drive different clinical problems. So disordered airway function drives symptoms, obviously very important, and we know we can modify that with bronchodilators particularly. Type 2 airway inflammation seems to particularly be associated with asthma attacks. We know we can modify that with different treatments. So it isn't adequate now in the 2020s to just identify variable airflow obstruction. That's a good start, but you need to go beyond that and look and say, okay, this person's got asthma. What type of asthma do they have? And how should I treat it? What are the treatable traits here? And what's the most rational treatment approach?